Hello, hello, everyone. It's so funny because normally I always see myself with Liz, so it's funny to just see me. My name is Chris Tronson. I am here today. I'm not going to be solo. Liz McInville will be here any moment. So as soon as you see Liz pop up, will be when I know Liz is here. She's just in something right now, but she'll be here pretty soon. So welcome. Today's Ask the Expert. So what I was recognizing is I don't think it's just been Liz and I for a hot minute. We've had Allegra Castens, we had John Hirschfield, we did a live stream last night with Val, Brooke, Melissa Mose, and Liz and I about the conference. We had Jenna Overbaugh. So I think it's probably been like 2 months since it's just been Liz and I. So I'm excited to get to your questions. That's going to be the main focus for today. So this is your stream. So Ask the Experts is all about you. So in order for it to be a successful stream, I just need you all to ask us questions. So this would be an awesome opportunity for you to ask questions. What are some things that you may be wondering about OCD or OCD treatment? What are some things that you're struggling with? What's some information you heard and want to get some clarification on? So definitely hit up that chat, say hi. I see Amy from Wisconsin. Hi, Amy. So everybody just put in the chat where you're from, who you're here to support. Are you here to support yourself? Are you here to support others with OCD? We'd love to hear from you. So just a little bit about myself. So my name is Chris Tronson. I have OCD. I went through very severe OCD. I actually spoke at a support group on Monday night and told my story as well as talked about mindset, which I'm going to figure out a way to do a live stream on the mindset needed to get better from OCD. But yeah, so we did I spoke at this group and I was talking about my story. And I recognized it's like I had OCD since I was a little kid. And I think probably for everybody watching, even if your OCD was massively loud at one point and became severe, when you look back to your history, you see so many little things. So I've dealt with OCD since I was a small child. And now I am at a point where I went to treatment because of severe OCD and got treatment. And then now I'm doing amazing. I'm doing really well and have my OCD managed. And I went full circle, became a licensed therapist. So I treat OCD, body dysmorphic disorder, and related disorders in Orange County, California. And I also am on the board of directors for the IOCDF, vice president of OCD Southern California, and a lead advocate for the IOCDF, speaking about OCD and helping to stomp stigma. And I'm part of 4 of their special interest groups and on leadership for 3. So I'm excited to be a part of that. So today I'll be answering your questions from both a clinical and lived experience lens. We also have some pre-submitted questions that I'll get to. And like I said, Liz McInville will be here any moment. So make sure for everyone to say hi and say where you're from. So Dave, it's good to see you. Amy, as always. Nirvana, it's good to see you as well. Nirvana, you'll have to let me know, are you Nirvana because of the feeling and experience, or is it more so because of the group, the band, the 90s band? Hi, Nathan from Athens, Georgia. We have Jen and Chantel. So it's good to see everyone. And Grace from Michigan. It's good to see you, Grace. My parents, I don't know if I said this, my parents actually met in Michigan. They both went to the University of Michigan, the Wolverines. That's how I always remember the Ann Arbor. Erica, it's good to see you. Good to see Erica. And feeling, yes, we all want to feel Nirvana. That's how we get rid of OCD. And Nancy, I see your question, so I'm definitely going to answer that. I just need to do a quick intro announcement. It's really brief. So this live stream is educational and is not intended to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Remember, the IOCDF is not a crisis hotline. If you are in a crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Hotline by dialing 988 or going to 988lifeline.org. And we want to create a safe and space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. And a note that this is being broadcast on several media platforms and is being recorded. So people can definitely check that out let's say you see something today that you think would be helpful for someone, you can definitely send them the link. Don't forget that the online OCD conference registration is open. It's Saturday, October 21st and Sunday, October 22nd. If you go to iocdf.org/online OCDcon, you can register and get more information. The other exciting thing is starting this Sunday to next Saturday, it is OCD Awareness Week. Where there is going to be so many activities. I know OCD SoCal, we're throwing a virtual event that everyone can attend. So I'll definitely talk about that on the live next Tuesday. Tuesday evening, we're doing a live with all 6 national lead advocates. So I'll talk about OCD SoCal's event, and everybody is invited. We have some really great guests, and it's a virtual event. Anyone can attend, but there's events happening all over the country. So there's both virtual events and both live events and virtual events. So those are going to be great. All right, so I'm going to do a couple pre-submitted questions, and I see we have a live question as well. So this question was a pre-submitted question. I'm going to put that in the chat. And someone asked, can you talk more about sexual orientation OCD? So so sexual orientation OCD is a subtype. It used to be called homosexual OCD, but we recognize now that it can impact people of every gender identity and sexual orientation. So they called it sexuality OCD, but the term is sexual orientation OCD. So the main example and where we see it the most is, let's say somebody's heterosexual. I'll use kind of a guy example, but let's say he is a heterosexual. He's in love with his girlfriend. He's thinking about proposing to her, and then he starts to doubt his sexual orientation. So remember, the difference between having OCD and not having OCD is there's never an incident with OCD that makes sense to respond to it. So it's not like he started dating a male or was interested in a man. He just had it where he started to have that doubt. Could I potentially be attracted to men? And because we give into OCD and we start to doubt and ask those questions and all of those things, what ends up happening is people start to get really, really in their heads. They start to doubt it. They start to do compulsions. They start to check. And one big thing that they do is, like, while they're with their girlfriend, they might check the whole time. Am I still into her? Do I like women? Should I get engaged with her? The problem is, the more you doubt, the more you question, the more you try to figure out, what starts to happen is you start to not trust yourself. And then, because it's around sexual orientation and love and intimacy, people get out of their feelings and into their head trying to figure it out. So then what ends up happening is they start to doubt and start worrying that they might not be straight. And then they start to find themselves doing compulsions and going back and forth. And this isn't, once again, somebody who's genuinely trying to figure out their sexual orientation. It's strictly just somebody that has OCD. So the treatment for this subtype is the same treatment that we see for all OCD. What that person needs to do is recognize, like, hey, there was never a reason for me to question this in the first place. I have OCD. I know I love my girlfriend. I know I'm excited to propose to her. But unfortunately, OCD put doubt on that. And I bought into it. And I started asking those questions and started answering those questions. Rather, let me take a step back. Let me stop answering those questions. Let me stop trying to figure out. Now, that seems irresponsible, right? Everybody watching that has OCD can agree. It seems very irresponsible when we take a step back from trying to figure something out. We start to feel like, well, is this okay? Am I going to get sick or be wrong with God or hit somebody with my car or not know my sexual orientation, whatever your subtype is? But actually taking a step back and not asking is going to start to quiet the brain. And then people get the clarity they're seeking. So I've worked with plenty of clients with sexual orientation OCD, and what ends up happening is when they stop trying to figure it out, when they stop, misreading bodily sensations or thoughts or feelings, what ends up happening is they get that clarity. And then they're like, no, I know I am absolutely attracted to my girlfriend and want to propose. So that is definitely something that a lot of people deal with. So the person that asked the question, you are definitely not alone. All right, I'm going to do a couple more pre-submitted and then a couple live. So the next one is, how does manifestation work for a person with OCD? What if we have a stupid thought? Hey.
Hi, sorry guys. Here I am.
No, it's all good.
Real life, running late, double meetings, you know me, so I'm here.
I just noticed that you kind of match your shirt matches your painting.
Yeah, it does. Look. That was but I'll pretend like it was.
And we both have floral patterns.
There we go. How are you?
I'm good. I'm good.
I feel like it's back to back. We were on last night till 7:30, and here we are again.
Yeah, I was saying that this is the first live that we've done for a while, just us two, because we had Allegra for a couple, we had John Hirschfield, we had Jenna Overbaugh, we did last night with other people with Val, Brooke, and Melissa. So this is like the first one.
Yay, so excited. I feel like we have 500 questions too in the document we need to go through. So
Yeah, I started getting some of those, and we have a couple live ones. So I was just about to read the second question, or yeah. So because this one I get a lot. I know Allegra even addressed this once on her Instagram. So how does manifestation work for a person with OCD? What if we have a stupid thought, which is purely an intrusive thought? How do we know? So obviously, if people aren't familiar with the manifestation movement, we saw it a lot in The Secret, which was a book that talks about it. So the idea behind manifestation is if we can like visualize something we want. So let's say somebody really wants a new car. The person's going to sort of visualize that every day. They're going to wake up, and maybe they're going to write a check for the cost of the car, even if they don't have the money. They're going to talk as if they have the car, and they're going to sort of just bring it out of their essence. And the idea is like the universe is going to align and things are going to come together. Maybe you'll get a raise at your job, or maybe you'll start saving money, but you'll somehow get that car. Not the idea that you're going to manifest and the car will show up, but just by like speaking it into existence, it will come through. Some people are really connected with that. Some people aren't, but I know it gets people stuck with OCD because the idea is like, well, what if I manifest killing my daughter because I had these visions about hurting her? So maybe Liz, you could talk a little bit about the difference between, and maybe you could talk about the faith component as well, because that's the other thing I hear is a lot of people will say, well, at church and in the Bible, it really talks about like having purity of thoughts. And I don't have pure thoughts. Does that mean I'm going to go to hell? So I see it in both religion and manifestation.
Yeah, no, it's a great question. So, I always tell my patients, I'm like, wow, if our thoughts had so much power, and if they were so real, can you just think the thought of like, I'm going to win the lotto? Because I really could do a lot of good with that, right? And it's like, well, Liz, it's not right. And so first of all, I just want us to remember that there's a very big difference in this kind of like the book, The Secret, right? Of like having a positive mind frame and kind of having this mentality of like, I don't want to be stuck in the negative, and instead I want to like wish good things, and and it's kind of a lot about like how your frame of reference, right? How you see the world, the lens, right? And we've been talking about this for our whole life, right? Do you view the glass half full or half empty, right? Like all that sort of thing. That's very different than OCD, and I want to be very clear about that. OCD gives you these unwanted intrusive thoughts that are followed by this immense amount of anxiety and distress, which cause you to feel like you need to do a ritual to feel better, right? In treatment, we're trying to teach you to do different things, but again, you are not wanting these thoughts. You're not manifesting these thoughts. These thoughts come on their own. These thoughts are given to you. They're pushed upon you. No kids today, Cash, but great question. So I'm finally at my office, so it's quiet, thankfully. Last night, you guys, I was like muting in between us talking because Olivia was screaming in the bath. And I was like, this is crazy here in my household. But anyway, so there's such a big difference, you guys, in like, I want the thoughts, I'm thinking the thoughts, right? And sometimes your OCD makes you think you want the thoughts, right? But these are unwanted thoughts. You don't want them. You wish you didn't have them. It's very different than thoughts that we're manifesting and we're wanting and that would make our life better. And so I want us to be really thoughtful about that. Treatment, however, is we are allowing space for the thoughts. That doesn't mean we're manifesting them, right? Chris and I have done a lot of talks on you don't have to accept your worst case scenario as truth. So it's not like we're sitting there trying to think of the worst case scenarios and leaning into them and trying to manifest them. That's not what we're doing as part of treatment. We're not hoping these scary things come true and trying to make them come true. Instead, what we're asking you to do is to be able to tolerate the distress of letting the thought be there and not responding to it. So not responding to a thought is completely different than manifesting a thought. And I want to be very clear about that. Some people think ERP treatment means we have to manifest our worst thoughts and that we have to like lean into these terrible, scary things and be okay with it, when actually that's not what treatment's about. Treatment's about allowing space for a thought and choosing to not respond to those thoughts.
Yeah, no, you nailed it. I'm glad that you explained the difference because a lot of people get really worried about that. I'm going to throw up Amy's comment and question at 12:08 your time, Brennan. So Amy says, I've shared some resources to a mother of a son with OCD, including referring her to my group, my mom and I's group, IOCDF, Anxiety in the Classroom, and articles from NoCD for people with a loved one. were some of them. Can you recommend others? So I was thinking like the first three that come to mind is I know Kim Vicenti. She has a Mom Mondays, Mom Mondays. Yeah. So she's at, what's her nonprofit? Oh shoot, let me look that up.
It's something about
Nonprofit. It is it's like Jack. Oh my God, this is gonna. Kim, I am so sorry. I totally know it usually off the top of my head because I refer a lot of people to it. Okay, it'll come to me, but I'll find it.
health advocacy.
Yeah, say that one again.
Jack Mental Health Advocacy, and Jack is all caps.
Yeah, so she does a Mom Mondays where she speaks to other moms. The second one that came to mind is I know the space program is really, really helpful. That's Eli Liberowitz. Talks about space, and what space really is, and what I think it's great is a lot of times parents are struggling because their loved one isn't willing to do the work or isn't making changes, and space really allows the parents to really have support and figure out a different way to handle and manage the situation so that they have some power. I also know that he said it was coming out last year. I haven't seen it yet, but Alec Pollard, there's been some great stuff that he's talked about where he's spoken at previous conferences, and he said he's going to write a book, and his book is similar in the sense of like, what can family members and loved ones do if they have somebody who's really, really struggling with their mental health. Also, I know John Hirschfeld has written a book, and John Abramowitz has written a book. Both of them have written books for actual family members and loved ones of somebody with OCD. So I think that those two books are really, really great. Any other resources for families that you could think of?
I think you can, of course, just go to iocdf.org, and the online conference and the live conference have entire family legs and entire family sections that I know for my family that was so meaningful for them to get to kind of hand select what talks they wanted to go to, but also the conference was a place they got to meet other family members. And I think that was really important and critical in my mom's journey of being a mom with OCD, was meeting other parents of children with OCD. So the conference is definitely a place I would go as well.
Yeah, I didn't even think about that. The conference coming up would be great. And we've done some live streams on family support. So definitely that. But I would look at John Hirschfield's book. I think it's called like Loving Someone with OCD, and then John Abramowitz's book for family members with OCD. Both of those are really, really strong books. I've read both of them because our family group, we always recommend them. So people started asking questions, and I had already read John Hirschfield's, but I was like, I want to read Abramowitz as well, but both of them are great books. So hopefully that's helpful, Amy. Chantel asks at 12:12, she says, hey, I have a question regarding reassurance seeking. I love watching these live streams and podcasts. One of my core fears is that I'll be mentally unwell and lose my children. Are these live streams and groups I join considered reassurance seeking? I hope not, LOL, as I feel a sense of community.
It's a great question, and it's one we get a lot, is like, sometimes people feel like, well, when I'm talking to someone about OCD, like, is this reassurance? Is this serving as reassurance? So the answer is no, but maybe, right? And what I mean by that is that coming to a webinar and learning and getting education, that is not reassurance. However, if you are coming to the webinar and you are confessing, I'm not saying you're doing this, but let's just pretend you're confessing in the chat and you're wanting to hear other people give you reassurance, then yeah, that's going to be reassurance. So again, I want us to be really thoughtful, because this is a question I get all the time, is individuals with OCD will start to get really anxious of like, well, I don't want to be undoing treatment, or I don't want to be, engaging in a ritual. You typically know when it's a ritual. So again, I want you to think about the functional behavior. Am I going to these webinars because it gives me community and I learn and I grow? Or am I going to these webinars to try to feel better about a thought that I have right now? Right? And if you feel like functionally it's just like reducing your anxiety in the moment, then you have to kind of think about, how am I making it a ritual, and what can I do so that it doesn't serve that function? And instead it becomes just educational community building. But something that's educational community building, that's amazing. That's incredible. That's useful. That is not reassurance.
Yeah, I was just going to say, I did a talk on Monday at Michelle Whitkin's group. By the way, one of the people who joined said they watch our live stream each week. So I don't want to say the name because of HIPAA, but they shout out to them if they're watching. But, I was speaking about the mindset that you need to be into to overcome OCD. And one of the things I talked about is don't be in the mindset that you have to do this alone. So Chantal, you and a lot of people I know for me, my support system was very small. I wish there was live streams like this, and podcasts and all those things. So they're great information. It makes you feel that you're not alone. It gives you support. It recognizes that people are out there researching and treating and helping OCD. So we're happy to have you. The only time I see it be a compulsion is sometimes, like, if people have OCD around their treatment, they're like, I'm listening to all these different podcasts to see how people got better so I could do what they do. But you would know the difference. It's in this like very like urgent panic way, and they're not even really paying attention. But from your comment, looks like it's giving you community. Nancy at 1205 says, hello, Pittsburgh. My son has OCD and has just been diagnosed with pretty bad body dysmorphic disorder. Looking for intensive care for him. Any advice? So Nancy, there's different levels of care. So a more intensive than outpatient would be intensive outpatient program. So that's where I do an intensive. That's where somebody's going to come into treatment Monday through Friday, multiple hours a day, usually around 3 to 4 hours a day. And then a step up from that would be partial hospital programs. And that's going to be more usually like 6 hours a day, Monday through Friday. And then there's residential, where somebody actually is pretty much there all day, typically living on site. So I know Liz can talk a little bit more about that. So what I'd first do, Nancy, is whoever diagnosed him, typically it's like a therapist or a psychiatrist. One of the things that I do when I do my intakes and I diagnose someone, I'm very honest about the level of care that they need. Sometimes I refer people to Liz's program. We don't have a residential in California, or I'll refer them to Rogers Partial Hospital if they want to stay in California. You want to make sure somebody gets the right level of care. I always think about, somebody with OCD and body dysmorphic disorder, trying to get it once a week is like putting a Band-Aid on a dam. It's just not going to be enough. An intensive sometimes is. Our intensives one-on-one, people find that helpful. But even sometimes that somebody comes to the intensive for 3 hours a day, but then goes home and is compulsing the rest of the day, and a partial hospital or residential might be better. So the good news is that the IOCDF actually has specific search function for that. So if you go to iocdf.org/find-help, what you can do is, instead of just doing outpatient, it goes into the filters, and you would put either intensive outpatient or IOP, partial hospital, PHP, or residential, and it's going to list all of those. You could find one that's either in with your insurance or in an area for you, and you want to make sure one feels comfortable treating BDD as well, because some of them are going to be heavy OCD focused. How do you know it's right for someone to come to your program, Liz, for like a higher level of care? What usually are some of the things you're looking for?
Yeah, I'm going to hop in for a second. I would look into UPMC's program. It's run by Dr. Hudak. They have an incredible IOP and PHP in Pittsburgh. I worked there and really recommend it. And they also take insurance. So it's a great option in Pittsburgh. So I don't know how many of you are from the Pittsburgh area, but UPMC is a wonderful resource. And Dr. Hudak's on our scientific advisory board, runs that clinic, and is very great. They also have a child program there. In addition to that, right, it's twofold. So during the admission process, we are trying to understand, what are your symptoms? What are you presenting with? What are your treatment goals? And can we meet all of those needs? So are we the right program to meet your treatment needs, to meet your treatment goals? Do we have the right setup for what you need for your acuity, your symptoms, your level of care, what you might be going through? A lot of times, I want to be very clear, OCD is often comorbid with another condition. And so if somebody has a comorbid condition, we want to know, what is that condition? Can we treat it? For example, we cannot treat active substance use at our program the way we're set up. And so if somebody was presenting with that, we're going to talk to them about options that would make more sense than our program. So that's number one. But the twofold part is that it's also your job to make sure you think we're fit for you. So does it feel like the right program? Does it feel like this program is going to help meet your treatment needs? Is it the setup that you're looking for? And what I want to be really clear about is that should continue to happen when you arrive. We tell all of our patients that you're on a 2-week trial when you come here. And what we mean by that is that at the beginning, over the first couple of weeks, we want you to kind of be interviewing us, and for us to be interviewing you to an extent of like, we're getting to know you, we're getting to understand you. And so we want to make sure we're the right fit. We're not going to take someone's money if we're not, and we aren't going to, keep you here if we don't think we can help move you towards your treatment goals and get you back to the life you want to be living. And you should be doing the same thing as you're at a program. If a program doesn't feel right, if you're not able to make the relationships with the therapist that you need to have, you should be thinking about that as well, and thinking about what other options might make sense.
Yeah, the other thing is, I quickly put in the chat for you, Nancy, or I'm going to have Brendan put in the chat. The IOCDF has a BDD special interest group. I'm one of the leaders. I specialize in working with BDD, but email us. So what we're doing is right now, the BDD special interest group is we're putting together a BDD conference for next year. And we want to hear from parents like you of what is the content. We're going to obviously do content for clinicians, but we're looking at what content do we want for people with BDD and parents of. So it'd be helpful to hear from you what you hope to get out of the conference, and also we can send you some resources. But I'm loving that Liz knows somebody in Pittsburgh, because obviously if you could find someone nearby. So reach out to info@iosdf.org with any other questions. Erica makes a good comment at 12:16. One thing I wish that could be changed in faith is being what I call thought police. It really helps no one, but adds a ton of guilt and shame regardless if someone has OCD or not. I want to transition this into a question, because this is something I hear a lot. And I'm going to have you more so talk from lived experience, Liz. How do you prevent yourself from feeling I was saying shame and guilt at the same time. Guilt and shame from the content of your thoughts, because I think that that's something that people with OCD really struggle with, is owning that. And I hear what Erica's saying on top of that. Sometimes in faith, or like I said, with manifestation, there's an additional layer to people feeling guilty. But how did you navigate that? Because it's really tough.
Yeah, it's a really good question, and I think that part of why we feel so guilty and shameful is that these thoughts that OCD throws at you, the ones that stick, are the ones that are closest to your heart, right? That are go against your values, go against who you are as a person. And so that's why they're really scary, right? If these thoughts weren't accompanied with guilt and shame, and we didn't care about these thoughts, they probably wouldn't stick, right? It probably wouldn't be under the OCD category or lens. So it's important to remember that and give yourself that assurance and grace, not reassurance. But what I always say is that I think it's okay to just remind yourself that, like, this is not me, this is my OCD, but to start doing ERP, and to remember that when you do ERP, those associations that you have with the thoughts that right now feel so connected to you will start to break, and you'll be able to have really good clarity that, like, that was my OCD, that wasn't me. And when you're able to have that increase in insight because you've done ERP, in my opinion, the guilt and shame starts to wipe away as well. Now, of course, many of us as clinicians will do some guilt and shame work while we're doing ERP, but I've also found that it gets addressed, kind of like if depression is secondary to OCD, it can also be addressed during the process of doing ERP.
Yeah. There was a quick question about
questions at you, Chris. Sorry.
What? No, it's okay. There's a question about the two books that I mentioned. So the two authors are John Abramowitz and John Hirschfield. So Kathleen, I see your question at 12:20, but I put them in for Brennan so he could show that.
No, it's my turn to ask you questions.
Okay. I was just gonna say real quick. Let me answer Cash's just because I do
that.
Okay, you go.
So Cash 1119, you said, is there anything on the long-term negative effects of OCD on the mind? As in, if 95% of my life has been OCD, is my brain still able to be rewired? I love this question.
Yeah, no, that's why I was excited to ask that. So Dan Spiegel, I think I was talking to you about it, Liz. I was talking to Kim Quinlan, someone, but he is really, really a genius. Writes books about the mind, is a scientist, and has written The Whole Brain Child, which is a great book. But he came and spoke at my grad school, and I remember asking him this very question. I was asking him, like, when somebody has severe OCD or depression, for instance, and they go most of their life, can it rewire? And what he said is yes. He said the great thing about our brains is we have neuroplasticity. Our brains are like supercomputers that want to learn. But because we have so many things going on in our daily lives, over time, our brain needs to compartmentalize things so it becomes automatic, so it can leave room for new information. The way that that's true is, like, when we get in the car, we don't actively at this point think about putting our seatbelt on. It just kind of happens. Or when I brush my teeth, I'm always listening to music when I get ready. And I'll forget, oh, did I brush these teeth? Because I'm just not even paying that much attention, because it's almost automatic. So the brain wants to learn new things. Now, what he did say is at the age of 60, on average, is when the neuroplasticity starts to go a little bit, it's more difficult to have neuroplasticity. And neuroplasticity is a fancy term. I think of the brain as like putty. It can mold, right? Learn new things. And after 60, unfortunately, it starts to become harder and harder. But what he said is there's a lot of things you can do even after the age of 60 to prevent that. So being active, learning new things, taking classes. He was saying even on like your phone, those games, not the fun games, but like the learning games and stuff can help. But the good news is he's like, yes, you can reteach yourself. And that's really what ERP is doing. When I was reading a study by Edna Foa, what it talked about, and UCLA did a study as well that I read, is your brain starts to learn and change its relationship with what was once perceived as negative stimuli. So the good news is absolutely you can. And medication can help as well. So if somebody is been with OCD for a very long time with severe OCD, medication can help that process as well. It helps work with the neurotransmitters to help that learning happen and stick.
100%. Next question from Stephen at 1121. I myself have had many subtypes, including cheating, child abuse, sexuality, sexual abuse, and I feel really tired. Are there many people like me, or is it rare to have all types of OCD?
Yeah, it's definitely typical to have different subtypes. And the reason is because the subtypes have to be relevant to you in that moment. So some of the OCD that I had as a child that was very relevant to me back then isn't really relevant to me now. So some of the subtypes I had, I've gotten over, but it moved on to different things. So like you, Stephen, it was like when I was younger, it was definitely like magical thinking. If I did this, my mom would get hurt. And then it shifted to contamination and checking, but then it went to intrusive thoughts around sexual harm and harm OCD, and then to relationship OCD. I never even knew relationship OCD existed because I wasn't in a relationship because I was housebound. So it definitely can switch. So I don't want to say good news, but so you don't feel alone. The good news is that it's definitely common. Now, one of the things that I found most helpful and something I do with my clients because of how helpful it was is when I started to think of every subtype as its own separate disorder, it was very overwhelming. But what my therapist and I really worked on is like, what's underneath it? What is some of the core fears? And what I started to recognize is a lot of the core fears were the same once I started to kind of go down and look what was deeper. So then it felt less about the stuff on the surface. So an example is I was really afraid of anything bad happening to me because I already felt like I missed so much of my life because of OCD. And I was like, okay, I'm ready. I'm getting better. And so a lot of my OCD that happened towards the end of treatment was all the core fear was that I was going to do something bad. I was going to be locked up and miss most of my life. And so I started realizing it wasn't really about the different harm and sexual and all that stuff. It was more so about this fear of losing control and then going to jail or not being able to like move forward because I've done something so wrong. And so we stopped focusing on the surface stuff and really kind of focused on that more core fear. So you'll start to see how OCD, after a while, all the content isn't as relevant. It's really about the doubt, the fear, the cycle, and all that OCD cycle and all that stuff underneath.
Absolutely. So many people talking about how you really kind of do learn reassurance and when it is reassurance. All right. Paul at 1124, my time, Brennan. Hi, team. I have a sister who suffers from schizoid personality disorder. Her issue, she keeps on talking to herself. Is this a type of OCD? She keeps on thinking and talking to herself. Do you want to take this, Chris, or do you want me to?
Why don't you take it? Because I have to read it and I'm looking for, it's up. Why don't you go first and then I'll go second?
Yeah, so typically when individuals are talking to themselves, especially if they're having any like auditory or any sort of hallucinations, visual or auditory, this would not fall in the OCD category. In addition, schizoid personality disorder would really want to be treated first. That doesn't mean that someone can't have a comorbid OCD condition, but we would want to treat the personality disorder first and then see kind of what's left, where OCD is, and when they're ready to be treated. What we know is that if someone has active schizoid personality disorder, it would prohibit or interfere with OCD treatment. So we would do that treatment first.
Yeah. I was going to say, I did work with somebody who had schizophrenia and OCD, and his schizophrenia had been managed. And so when he came, he actually did really well in OCD treatment. So I don't have much to add, except I agree.
Next question at 1125 from Craig. What do I do if I just feel like giving up because I don't feel like there's hope anymore? So this is such an important question.
Yeah, no, good question, Craig. I actually got that question on Monday as well when I was speaking. There's a lot of different factors that can be supportive. I think the biggest thing for you is to figure out what do you feel like is missing in your recovery. I talk to clients, I'm Greek, so I like to use Greek mythology, and I'll tell people, like, think of Achilles, right? Achilles heel. Like, what is the one thing that you feel in your recovery is preventing you from making enough successes that it gives you that motivation? Because that's what really pumped me up in my treatment, and that's what kept me going, is this concept and this idea of success. And so when I started getting to a point where I'd come home, and when I was at my worst, my dad was like cooking my food, he was cutting it up for me, he was even like feeding me with a fork because I just couldn't do it. But I remember when we got to the point where my dad would cut up the food, microwave it or cook it or whatever, and then I would eat it. That was a huge win, because I was like, oh my God, I'm eating my own food. And then when I could make my own food, right? So those successes gave me motivation and kept going. So what I would ask you, Craig, is like, what do you feel is the thing that's preventing you from that? Is it a lack of community or a sense of people that are on your side or who understand? Maybe you haven't opened up and shared with anybody about OCD. I have a client that finally shared with his friends and his coworkers about his OCD because he was just tired of dealing alone. He doesn't have a lot of family support. And he was like, I could tell they didn't understand, but they have been so supportive and asking me about it. And it gives me renewed energy. Is it the treatment? Do you need a higher level of care? Do you feel like you're not with a specialist? Do you feel like you're not making treatment a priority? Is it feeling like it's whack-a-mole and it's chasing around and it's different subtypes and you feel like you're running it? So maybe you could put in the chat, Craig, like what you feel specifically is kind of missing. But overall, just to answer the question, overall, I'm going to validate it. It's exhausting. There was definitely days in my own recovery I'd wake up and I'm like, I just don't want to do this. I'm over it. I'm tired. I just want to sleep the day away. I don't want to deal with this anymore. But what helped me is just leaning on my mom, leaning on my therapist. And I think too, it sounds like a small activity, but what I would do sometimes when I was in that mindset is I'd journal all the successes that I had. And when I would see that list, I'm like, oh my God, I've made a lot of headway, and success motivated me.
I love that. Yeah. And again, remember, Craig, if you're feeling unsafe or suicidal, we want you to take the steps you need to take to keep yourself safe. And I know for so many of us, so that's 911 or 988 now, our local emergency room, it is depression and hope. It's easy to lose hope when you're in the middle of a mental health journey. But what Chris and I, our goal across anything that we do is our goal is to send a message of hope that it will get better, it can get better, and with effective treatment, you can live the life that you want. I know that's hard to hear at times, but the first step, of course, is keeping yourself safe. But the second step is to really be able to get to a place where you can get good treatment so that you can have those outcomes. And hope isn't something you have to search for, it's something that you get every day. Next question. So I am... yeah, there's a question about medication. We really don't answer medication questions because we're not medical doctors. So I'm going to kind of jump past those. I want to encourage y'all to please consider going and talking to a psychiatrist to get medication advice. We really don't want you to even put it in this chat and ask each other, because it's different for every person, and we would never want someone to make a change or do something different without the advice and guidance of their own personal psychiatrist.
Yeah, what I was going to say real quick, SO, is you reminded us, because I just put your question on our doc when we have a psychiatrist on. And what I just realized is we have a lot of medication questions. So SO, please don't think that please don't think that we're ignoring you. It's just that the way that our ethical and laws are written is like, we just can't prescribe. But what we did is I put your question down because it's important to us. What we'll do is we are going to reach out. We have a great team of psychiatrists that have come on this live before. We'll definitely make sure to promote it, and we'll come back for that and answer your question. The other thing is OCD SoCal, we're doing an OCD Awareness Week event. So if you just email us at info@ocdsocal.org, and we're getting a psychiatrist on that event. It's Saturday the 14th, 11 to 1 Pacific Standard Time. And so you could ask your question there too. But we care about it. We just didn't want you to think that we just can't answer it, unfortunately.
We're not equipped to answer, right? And I think that really is what goes to what Chris and I do, is that we're really strict about like the treatment, even that we offer in our own, clinical work, is, are we equipped to treat you? Are we, if you are suffering or dealing with something that's outside of our wheelhouse, like we shouldn't be treating you if it's not our expertise. And that's just the reality of medication. We're not a psychiatrist, so if we gave advice, it'd be from our own personal experience versus advice from a clinical perspective. And we really try hard never to do that, right?
Yeah, the only thing I wanted to add is a lot of times I'll see at events where there is a psychiatrist panel, and I would say one of the biggest questions is your question about dosage. There is a really good article. I'll find a link. It's from Dr. Michael Janicki, who obviously we all look up to and has led the research on medication. There is a good article that we'll put in the chat. I'll give it to Brendan in a second, which talks about the necessary dosing. And one thing that you can talk to your psychiatrist about is show them this article and say, hey, because a lot of people will say that they're on a lower dose than what that article says. And it's just found what the article says is that people need to be on a higher dose. So your question is valid, and it may just be that your psychiatrist doesn't normally treat OCD. So.
Yeah, and we have done a webinar with Dr. Stephen Poskar and others that you can look at on the YouTube channel if you want to watch some webinars where we have answered medication questions live. But I promise we will bring him or someone else back on soon because it's clear that we really need to do that. At 11:27 from Terracotta, hi Liz and Chris, with rhyming compulsions, how do you do scripts or any other exposures when my rhyming rituals is usually unintentional and I don't know how to stop neutralizing?
Can you start with that one? Because I'm trying to find that medication article.
For sure. So, okay, so many thoughts here, Terracotta. So let me jump in. So first and foremost, a lot of times patients will say, hey, my rituals are automatic or they just happen. And my response is like, okay, so let's worry less about if you did a ritual and more about the power that you gave that ritual. So for example, if you find yourself rhyming and it makes you feel okay, can you undo that exposure or that ritual? Can you lean into like, but maybe I did that wrong anyways, or who knows if I did that correct, or whatever would make it where that behavior doesn't serve as a ritual that serves OCD, and instead you lean into anxiety or you lean into the kind of distress that's there, right? So number one, can we take the power away from that ritual even if you do it unintentionally? So you can always undo a ritual, you guys, right? I'm never going to have someone never wash their hands again, but I really do want you to not be washing your hands for OCD. And so if you wash your hands, we can recontaminate or do things that make it where it doesn't serve our OCD. Instead, it just serves our hygiene. Number two, I want to talk for this. That makes a lot of sense. I want to talk about this for a second. I think there's a lot of discussion and belief in our field that like, oh, we have to really focus on like stopping neutralizing or doing rumination disruption. I want to go back to the basics a little bit, you guys. Are we addressing core fears? Are we addressing what's at the root of why we are having the urge to neutralize, why we are getting caught doing these rhyming rituals? If we're spending our life just trying to not ritualize, we're not really getting to the core. And that is exhausting. And a lot of times when people talk about ERP and ERP being exhausting, that's exactly what they mean. And what they're talking about is, hey, I'm just doing all day, I'm doing exposures and I'm trying to survive, but I'm just trying my best to not ritualize. And so I'm just having to like push through not ritualizing. That isn't what ERP should feel or be like. ERP shouldn't be that we spend our day just trying so hard not to ritualize and we're basically what we call white knuckling, right? We're just kind of gritting through and surviving. Instead, ERP should be addressing those core fears that even cause you to rhyme or neutralize, or for someone else to hand wash, or do a reassurance ritual, or going through a threshold, or whatever it might be, whatever your rituals are. So when we address the core fears that caused us to do these rituals, what will happen is we don't have to worry as much about how do I stop ritualizing, because we don't even have the urge to ritualize anymore. And I'm really strict about this because one of the things I get really worked up about rumination disruption is that I don't believe rumination disruption is often active treatment. I think rumination disruption is a means in treatment, right? So sometimes it allows us to be able to move through and be able to kind of make our way through the day when we're struggling. But the treatment goal is that we address the core fears that even cause you to want to ruminate, right? I don't want you to have to spend your life disrupting your rumination or your urge to ruminate. I want you to be able to no longer even have the urge to ruminate, right? So I want us to think really bigger picture of like, instead of like just ERP where we're just addressing our current symptoms or our current subtypes? Instead, are we addressing what's at the core that even causes these things to be a trigger, right? I always tell people the goal of OCD treatment is that you have thoughts, but they don't become triggers, right? Because guess what? If they're just thoughts, we're not scared of them. Like, they don't have power. They don't mean anything. That's just life. That's just living. That's just our brain functioning. But if they become triggers, then that means there's still a core fear that's attaching to something, right? And if we actually address what's at the core fear, then guess what? Like, we don't have to be dealing with the urge to ruminate or the urge to ritualize, right? Those urges should go away. When you're in treatment long-term, OCD treatment should not be that every week you're dealing with the crisis of the week and you feel like you're putting out a fire around your current triggers. It should be that you are addressing the core fears and you're getting freedom across the board, not that you're having to like constantly fight against your OCD. Your OCD should no longer have a hold of you. And the fears that originally kind of kept you handcuffed, right, for your OCD, they're opened, right? They're gone, they're broken.
Yeah, what I'd add to that, it makes me think of a client who had scrupulosity, and anytime like the word hell or something like that popped up in their head, they would neutralize like you, terracotta. But the problem is the client was like, Chris, I promise you, like in the past it was deliberate and now it just pops up. I'll think of a good thought or whatever. So what we worked on is he didn't want to, and rightfully so, didn't want to deliberately like write hell and things like that. And I always try to work with the treatment with the client on what they want to do so they'll do it on their own. And one of the things he said is like, there's TV shows and there's movies I like and there's songs I like that I stopped listening to because it might have that word, or I think he likes like the horror movie like Hellraiser or something. So he would watch those and practice like actively not neutralizing. And then that sort of made him no longer triggered by the word. And that way, when the word popped up, he found himself not even unintentionally or automatically doing it. So just like Liz said, going from defense to offense for sure.
Yeah. And so many great questions. I love y'all's messages of hope and inspiration that you're providing to others about there being hope. Y'all are just such the best community. I love this and love you guys. For core fears, are the roots the reason? Is there always a core fear? Yeah, almost always, right? And sometimes the core fear is the fear of having anxiety forever, or the fear that I'm going to feel distress, or right. So it isn't always like a specific core fear of like, I'm going to die or you're going to die, right? It might be a more vague core fear, but there tends to be something at the root that is the reason our thoughts stick, right? When Katie always talks about stick with the ick, what she means is like lean into the uncomfortability, but we also have to figure out, why are things sticking? What are we actually afraid of? And when we do ERP, we want to be doing ERP and leaning into our core fears effectively so that those don't have the power. What we know is that if we only do ERP for our symptoms and we don't address the core fears, your OCD starts to shift. And that's when people talk about OCD feeling like this game of whack-a-mole, right? I address one thing and another thing pops up and I'm just constantly having to do ERP. That's not what ERP should be. ERP should get you freedom. It shouldn't just get you temporary relief around that one symptom, but then it shifts to another.
Well said. Yeah. And the core fear, Amy, like the way that I help clients reach their core fear is one of two ways. Like either we'll do an arrow down technique, or the other one that really helps sometimes is just writing a narrative or script out to OCD's worst case scenario. And I don't necessarily use them as like habituation triggers like they were originally designed for. I'm more so like, let's map it out. So for me, like when I was with my therapist and I was mapping it out, she's like, okay, what is underneath? And obviously like underneath the harm and the sexual intrusive thoughts, there was definitely like shame. I didn't want to feel like that. I didn't want to be that person, but I had clarity that I wasn't going to be that person. And so she's like, if you know you're not going to be that person, what are you afraid of? And for me, it was more like losing control. And I think that's where my fears of alcohol, I wouldn't even eat food cooked in alcohol or like a red wine vinaigrette. So I'm like, what if I get a little drunk and tipsy, do what my thoughts say I'm going to do, and then I'm going to end up be behind bars and have caused harm to another person. So causing harm to other people, like causing, family distress, is why I hated driving people in my car. What if I get in a crash and the person ends up dying and I survive? I'm gonna have a lot of guilt. And then the idea of like being locked up, my life being altered, and here's one more reason why I can't get to life. And those were the core fears. And then I started to notice how it showed up in all different subtypes, and we started to focus more on the deeper stuff. through exposure work and through education and cognitive behavioral therapy versus only the surface stuff. Driving my sister in the car was an effective exposure, but I had to know what it was tied to really make it effective.
That's right. So it's kind of thinking about like anything, right? But like I could teach my daughter math and she could kind of I can't really, she's 2, but let's pretend, right? But like I could teach her how to add where she's just like memorizing versus do I want to actually teach her like how to add, right? Like I don't really want her to memorize 2 + 2 is 4 because she could memorize that. I want her to understand what adding is, that it's 2 items plus another 2 items, and now we counted equals 4, right? Because you want her to learn the process. And so, one of the things we do here at our clinic is in the past, so during ERP blocks, we have two chunks of 2-hour ERP blocks a day. So all of our patients are getting 4 hours of active ERP. During that ERP block, we used to say things like, what were your SUDs? So what was your anxiety level before the exposure? What was it after? Right? But now our questions are things like, okay, what are you going to do this ERP block? How are you going to lean into your anxiety? And what are you going to do to practice response prevention? Our checkout questions after the ERP block, our main question, the only one I actually care about, is what did you learn? Right? Because again, it's not about did you do that one exposure and touch that contaminated cup? It's about, okay, what did you learn and what did you address that was more at the core and the reason why that cup even felt contaminated to begin with? Because if we address that, right, it will apply to so many other things that are contaminated versus I have to now do ERP for every contaminated item. When you're in your garden, if you use a weed whacker, right, like you'll get the weeds, the garden will look good for a day, but they grow back, right? We all know what it's like to pick a weed and see that root. It's like very fulfilling because like I got it. Like that one's not coming back. The other ones might, but that one's gone, right? And so we want to do the same with OCD.
Well said.
So many great questions. I don't really see today so many great questions, so many great comments. I don't see that much, more questions, but across the board, you guys are just so supportive of each other. I love it. And y'all give so many great feedback. And yes, if they could put medicine that could cure OCD, that would be amazing. Yeah.
I like the comment if we could put it up at 12:39 your time, Brennan, from Joyful Jalen about OCD being worse when trying to sleep. I was having a conversation in my support group last night. The thing about it is going to bed for a lot of people is hard with OCD because that's when your mind is racing. And so what happens for a lot of people is throughout the day, they've been sort of busy with work and school and distracted. And then when it comes down to like laying down in bed, suddenly all those thoughts come up to the surface. And it is really hard for them. And then they find, just like you, Jalen, is they start to find themselves like in that sort of fight or flight, which keeps us awake and alert and doesn't let us sleep. So one of the things that I ask clients is, okay, the things that are coming up at night when you're laying in bed, are you addressing those throughout the day? And they're like, not really. I'm busy, I work, I school, I don't really address it. So I kind of get hit with it for the first time at night when I go to bed. And so what I'll say is like, where can we find a chunk of time that you can work on it through ERP, through treatment, where you're addressing it way before your head hits the pillow. Just like Cash said, it's like when you're tired, your OCD is worse. You don't have the fight in you to fight back. So what I would say, Jalen, is if you can, is work on some of that stuff prior. So let's say somebody's laying down and all of their intrusive thoughts start to come to the surface. Have you been addressing those in ERP earlier that day? Have you made a patch? Because what you'll find is if you have, when it comes down to nighttime, it's like, oh, I already dealt with you at 5 o'clock today. I already know what you're going to say. I already know what you're going to try to get me to do. Like, I don't listen to you anymore. So just don't let the first time you're addressing stuff be late at night before bed. A small little, like, it's not treatment. It's just sort of like a little tool to help. I know for me, my thoughts were racing at night. So I got a sound machine and I used to sleep with that, and I'd turn it loud enough where it wouldn't keep me up, but it wasn't too loud that I couldn't sleep. It was like that perfect. It drowned out my thoughts. My psychiatrist recommended it, and he said, this isn't treatment, but you haven't been able to sleep in so long that, we need you to finally get a normal 8 hours of sleep. So it allowed me that kind of changing my sleep patterns and stuff allowed me to get good sleep for like a week or two. And then I was able to start doing the treatment, and because I had the sleep under me. So I don't know if that's a temporary hack, but the main thing you got to do is you got to be facing the OCD throughout the day. By the night, it's going to be weak, but if it's the first time you're facing it, it's going to be real strong and loud.
And just remember, right, when things get quieter, OCD tries to get louder, right? And so it makes sense, especially like if there's pressure on night that like I'm supposed to be less stressed, I'm supposed to sleep. Like, yeah, OCD is going to be like, no, thank you. I'm going to throw that up for a curve, but throw a curveball there, right? And so that's more the time to do ERP so that you can lean in. I have not heard of BWRT, Michael. Sorry, I saw that question earlier. I will definitely look into that. I don't think Chris has either. It's by Terrence Watts, Chris, but we'll look into that and maybe report back next in 2 weeks, because next week is our research roundtable. But just a reminder, please refrain by sharing any medication specifics of what y'all are doing for medication, because I want to be thoughtful that really should be guided by a psychiatrist, not by each other. But yeah, today was amazing as always. Thank you guys. I love our conversation. I love the comments. I love the questions. We now know we need a psychiatrist on soon, so we will be working on that. Next week is Research Roundtable with Dr. Bramowitz and Kyle King, so you will get to see them there and answer all the research. They will be there to answer all the research questions. Patty, we've done a webinar on ICBT that you can look up, but also I would encourage you to bring that to the Research Roundtable so they can talk about where the research is and where it lies for ICBT over ERP, etc. And yeah, we will see you guys next week. We love you guys. There is always hope. There's always help. Thank you for an engaging conversation. Chris?
Yeah, no, I was going to say, Michael, I bookmarked the BWRT by Terrence Watts. So I'll look at it. And then when we're back, so we're back in 2 weeks, right? I'll be able to at least give you our original thoughts on that. Don't forget, next Tuesday, Liz, myself, and all the IOCF lead and national advocates at 7 p.m. Eastern are going to be doing a special OCD Awareness Week live stream. So please join us for that. And then don't forget that OCD Awareness Week starts this Sunday. So there's a lot of different activities, including OCD SoCal. We're doing an event that's virtual and everyone's invited next Saturday. So it'll be on the IOCF's calendar page. Somebody asked about Shepherd Pratt. Yes, please reach out. John Hirschfield runs that. John Hirschfield's a great clinician. You just want to ask him if they have BDD specific care, but John Hirschfield is definitely a leader in our field and would be great to go. Thank you so much for the great questions. Felice, I see we didn't get to yours. Jalen, you had one more question. Like I said, we always put them on our sheet and we'll get to them at a future live stream. So join Liz and I every Wednesday at 9 a.m. Pacific, 12 Eastern, except the second Wednesday of the month. But we'll see you all back here in 2 weeks. Take care. It was great seeing you all. Thanks for helping us out and making this a great live stream.
And it's John Hirschfield's fault that I was late.